if I may. Okay. Look at the slideshow. There we go. Okay, so good morning. My name is JayVon Muhammad, and I am a candidate for a master's degree in the Maternal Child Health Systems program at Bastyr University. And this morning, I will be presenting my capstone project, Improving Birth Outcomes in Louisiana, by expanding the scope of federally qualified health centers to include freestanding birth centers. And so I want to start out with a big moment of gratitude before I can even think about presenting my project. And to do that, I have to tell you about the year I had while I attended Bastyr. I was living in Louisiana. And of course, the whole country and the whole world was on a COVID-19 pandemic reorganization. And then, as was I, as the leader of an FQHC, and then Hurricane Laura came in August of 2020. And Hurricane Laura was the strongest hurricane to hit Louisiana since the mid-1800s, and it was very devastating and destroyed not destroyed, but significantly damaged my properties. And as I learned how to recover from a hurricane, having never been in one, Hurricane Delta came 6 weeks later. So in October, we experienced Hurricane Delta, which drew another blow to my properties, and I was reorganizing my life to survive a hurricane. Same time going to school, no internet, no water, no electricity. Then in October 2020, while doing relief work for the hurricanes, I contracted COVID. Shortly after that, I resigned from my job in Lake Charles. And in December, there was that historic freeze that came to the Texas area, Louisiana area, and I experienced pipes bursting and all kinds of inconveniences from that. In February of 2021, I was awarded a new job, and in March, I moved back to San Francisco. And so that is a little bit about, excuse me for moving forward, how my year went. And so that makes me excited about thanking the people who helped me through these personal tragedies to complete this project. And so I first want to thank my boyfriend, Fitzgerald Darbone, who comforted me as I cried daily about the inconveniences in having to complete this work at the same time as that year I had. And I want to thank Jen, who you just heard from. And I really don't know how to thank you enough, Jen, because I witnessed true education and true social justice through this program. And I really think that this was one of the most amazing educational experiences that I've had. And I got to live the idea of social justice and justice in education versus the theoretical conversations that we have about that. And I just want to thank you for helping me in any way you could and always offering to do that. I want to thank my classmates because they did all kinds of supportive things for me. It was the words I was sharing the other day. One of my classmates Cash Apped me, to just help me through my journey. And so big thanks to my other classmates. And then Dr. Nancy Anderson, who contacted me for several years, encouraging me to apply for this program. And Karen Hayes, who helped me through the program. I just want to give out another thanks to both of them. And then Jessica Jolly and Diana Ross, who were on my committee and helped me through this project. So now I can move on. So again, I'm JayVon Muhammad, and what inspired my project was my previous work as a midwife. I'm a CPM, a certified professional midwife, and a licensed midwife. And for nearly the past decade, I've been a healthcare administrator, specifically leading federally qualified health centers. In California, I was able in my past to open one of 3 freestanding birth centers owned and operated by FQHCs. So the work is very interesting to me. And having had recently moved to Louisiana, I definitely wanted to see how that work could benefit the community. I'm a mother and I'm a grandmother, and I'm a member of the Black community. So all of these things informed my project, and I'm excited to tell you about it. So today our learning objectives are to define federally qualified health centers and freestanding birth centers, to explain how freestanding birth centers reduce cesarean section rates, ultimately improving birth outcomes, and also how freestanding birth centers save taxpayers money. I want to discuss the current state of childbirth in the state of Louisiana and the importance of federally qualified health centers in Louisiana owning and operating freestanding birth centers. And I also want to review the initial steps to FQHCs, or federally qualified health centers, owning and operating freestanding birth centers. So the specific aims for this project were to review and synthesize literature, and some of that literature included the current state of childbirth in the United States, the history of federally qualified health centers and their connection to the civil rights movement, the current state of birthing in Louisiana, including disparities in outcomes for Black women and birthing people, and the cost of childbirth in different settings. Also, a specific aim was to identify and summarize the relevant points that will influence federally qualified health center leadership in Louisiana to own and operate birth centers, and to produce a video that would provide technical assistance for FQHC leadership in Louisiana who want to own and operate freestanding birth centers. So the method that I took was to review literature from several databases, including PubMed and Cochrane Library, Google Scholar, and others, using a combination of keywords, including, I'm trying to move the pictures over, including but not limited to FQHC birth centers, freestanding birth centers, birth center cost savings, birth centers reduce prenatal disparities, perinatal disparities, civil rights, and FQHCs. So I used websites from non-governmental organizations also, and the World Health Organization. So just to talk about birth wars, or something I'm going to call birth wars. In the United States in 2019, there were 3,745,540 babies born in the United States. And Medicaid paid for nearly half of the US births at a cost of over $1.9 million per year. 98.5% of births occurred in the hospital setting, where the primary care providers were obstetricians, and they managed nearly 90% of the births in 2019. Black women and birthing people had the highest preterm rate at over 14%, while making up only 14% of the total births in the United States. Meanwhile, in Louisiana in 2019, I want to first recognize that Louisiana is 49th in the nation for poor outcomes, second to Mississippi. So there's a continuous battle for the worst place, and Louisiana regularly ranks at 49th. In 2019, 58,799 babies were born in the state of Louisiana, and 13.11% were preterm. 16.6% of the births were, of the preterm births were to African-American or Black women and birthing people. I want to take a moment to call out cesarean sections, because that the case against unnecessary cesarean sections was something that motivated me to do this project. And so just pointing out that the cesarean section is one of the most performed surgeries in the United States. The cesarean section leads to maternal and child morbidity and mortality. In the United States in 2017, nearly 1 out of every 3 births in the United was by cesarean section. And Black birthing people experienced the highest cesarean section birth rates at nearly 36%. In Louisiana, the cesarean section rates were so high that the Secretary of the State Department of Health and Hospitals wrote a letter to hospital CEOs compelling them to reduce the number of cesarean section deliveries. Approximately 40% of births in Louisiana were by C-section, and despite the state's efforts and the Healthy People 2020 cesarean section goal of 23.9%, in 2019, Louisiana cesarean section was 36%. So I want to move further into exploring what federally qualified health centers are and why they're important. So and they're also known as FQHCs. So FQHCs primarily serve the Medicaid and Medicare populations, providing healthcare access to low-income people, those who are uninsured and those who are underinsured. And they're just really important in allowing access to chronic care, that people wouldn't get if we didn't have this safety net. So the history of FQHCs goes back to the 1960s, supported by funding from President Lyndon Johnson's War on Poverty. There were two physicians who worked to start the first two federally qualified health centers. One was Black and one was white. One center was in Boston and the other in Mississippi. By 1971, there were 150 community healthcare sites throughout the United States. And today, there are nearly 1,400 FQHCs that serve approximately 30 million people. So FQHCs provide a safety net to the most vulnerable citizens. More about FQHCs, and this is key. There are 4 key components that define health centers and help them reach America's most underserved communities. So 1, FQHCs are located in areas of high need, usually areas that are designated as medically underserved. 2, there's comprehensive services provided at FQHCs, and they're based on the community needs. But at the base or at the root of FQHC services is a requirement to offer medical, dental, and mental health services. FQHCs are open to everyone, but our target population, again, is Medicaid and Medicare insured patients who are low income. And the board of directors for FQHCs are required to be 51% patient-based. And so that means that the patient should be informing the decisions about care at federally qualified health centers, which is very important. Who do FQHCs serve? Who's in that 30 million patient served list category? 2.9 million patients are 65 years or older. Over 9 million are children, 1.5 million are homeless, and almost 400,000 are veterans. 143,000 patients are receiving, probably more now, are receiving services for MAT or medication-assisted treatment therapy to serve opioid disorder. And most patients are uninsured or underinsured. So what I want to point out is that FQHCs do a great job at serving our low-income population, but they are also known as economic hubs in low-income communities. So FQHCs become the greatest employer in the community. They boost the economy by buying the needs like the supplies from community-based businesses, and also just that high amount of employee population eating at restaurants in the community and supporting local businesses. FQHCs also save taxpayers money, and we'll talk a little bit about that. So FQHCs provide, it has been shown that we do a better job at controlling diabetes and hypertension and chronic medical conditions better than when our patients are put in the world and they go to private practices, because FQHCs provide a well-oiled machine. And so when you come in, you not only get primary care, but you're referred to dental, you're referred to behavioral health. We often house WIC departments and pharmacies. So it's considered a one-stop shop, and it allows us to provide seamless care to our patients. We employ 253,000 people, including health care professionals, administration and facility, and staff support or support staff. Of interest to me is the revolutionary history of FQHCs, because the Black Panther Party actually had a lot to do with the modern day design of community healthcare. Back in the 60s, the Black Panthers had cities throughout, had chapters throughout the United States. And in 1970, acknowledging the unacceptable state of health and healthcare delivery to Black people in the United States, the Black Panthers directed all chapters to open community health centers. Initially, these community health centers focused on diseases that affected the African-American or Black population. And so one of those target diseases is sickle cell disease. But of course, that grew into just widespread community health services. So what is a freestanding birth center and why are they important? Much like FQHCs, freestanding birth centers were created out of a social justice movement and the desire to have access to options, quality, and safe birthing environments. The American Association of Birth Centers defines birth centers as healthcare facilities for children where care is provided in the midwifery model. I want to point out that freestanding birth centers are not attached to hospitals. And so there's a little confusion about the definition of freestanding birth centers, because a lot of times hospitals will market the concept of birth centers, but they're actually just upgraded areas in the hospital labor and delivery wards. And these are not the same things. Who works in freestanding birth centers? So freestanding birth centers are primarily midwife-led, and there are various types of midwives throughout the United States. There are certified nurse midwives, and these midwives are nurses who have went on to achieve higher education and become licensed as certified nurse midwives. Most certified nurse midwives work in hospital environments. There are certified midwives who are non-nurse midwives, but go through the same midwifery training that certified nurse midwives do, and they are licensed by the same licensing agency. They're only licensed to provide care in 6 states. Certified professional midwives are often not nurses. There are some who are nurses, but they're often not nurses. And they get trained through both an academic and an apprenticeship model. They are known usually as grassroots midwives or direct entry midwives. Most of them work outside of the hospital or birth centers. Many of them are home birth midwives, but there's a growing number of certified professional midwives who are working in birth centers. They're recognized providers in 34 states in the District of Columbia, but not recognized nationally, which poses some difficulty when we look at them being providers in federally qualified health centers. And then there are licensed midwives who are midwives licensed in their individual states. Most of the time, the states will use the certified professional midwife path as a part of the licensing process. They are usually not nurses, and they're also recognized in 34 states in the District of Columbia. Freestanding birth center midwives use the midwifery model of care, which includes minimizing technological interventions and providing, and really just looking at birth as a normal physiological part of a mother or birthing parent's childbearing cycle. So the case for FQHCs owned and operated by FQHCs, this should say, excuse me, the case for freestanding birth centers owned and operated by FQHCs. This important study really says it all. It makes the case for opening freestanding birth centers in Louisiana. And so this study was at the Family Health Birth Center, an FQHC owned and operated freestanding birth center since 1994 in Washington, D.C. And it demonstrated that birth center care leads to lower cesarean section rates and lower preterm delivery rates. After 6 years of operation, the cesarean section rate for African-American birthing people was lowered from 31.5% to 10%. There were also substantial decreases in the rates for both preterm and low birth babies for African-American birthing people. Preterm births dropped from 15.6% to 5%, and low birth weights dropped from 14.5% to 3%. And that is extremely important considering those 4 key components of FQHC care that we reviewed a little earlier. Freestanding birth centers also save taxpayers dollars. Remember, Medicaid pays for nearly half of the US births at a cost of almost $2.2 million per year. Freestanding birth centers save taxpayers money by reducing the cost of birth for birthing people insured by Medicaid or those who are uninsured. This cost savings is significant. In 2017, nearly 1 out of every 3 births in the United States was by cesarean section. When birthing people insured by Medicaid deliver by cesarean section, the cost of birth increases by approximately $4,000. And reducing cesarean section births to 15% would save the healthcare system about $5 billion. So that cesarean section piece of our healthcare industry, of our perinatal industry, not only cost the country a lot of money, but it also increases the maternal morbidity and mortality rate and the infant morbidity and mortality rates. And so we have to really do something about this. And that something is for more freestanding birth centers to be owned and operated by federally qualified health centers. So I just want to talk just a brief minute about the genius of this. On June 11, 2019, the Louisiana State Legislature passed Louisiana Statute Title 40, Section 2180.24. And this bill requires that all operating freestanding birth centers get licensed through the state of Louisiana. But essentially, it was a recognition bill. This bill had to go forth to forge a pathway for us to even open freestanding birth centers in Louisiana. So by recognizing freestanding birth centers and requiring licensure, the state of Louisiana has made a path for FQHCs to expand their models to include freestanding birth centers. And I want to take us back to one of the slides that I showed earlier, those 4 key components of federally qualified health centers. Remember, they're located in areas of high need. They have a comprehensive set of services. So if you are a birthing person and you enter FQHC for perinatal services, you are also connected to the dentist. You are also connected to mental health services. You are also connected to WIC services. You are also connected to pharmacy. This is the best care model for a pregnant person to be in, because it's not disjointed and it doesn't, we don't lose people in the system. Also, that these FQHCs are open to everyone, so you don't have to have Medicaid to come in and have your birth. You can also have private insurance and you get to benefit off of this really comprehensive service provider. And then again, that patient majority governing board, 51% of those board members are also patients. And so they are continuously improving the services at FQHCs. And so this model is the key to reducing cesarean sections, especially for Black and Brown people in the United States. What are the basic steps for FQHCs in their journey toward owning and operating freestanding birth centers? Well, the first step is to assemble a birth center work group team. And this team does all of the pre-work for setting up a freestanding birth center. They are gathering information about real estate. They are gathering information to inform the board. They are looking into architecture. They're doing all of that research to be able to inform the process. So they assemble at least 6 months, but probably a year before this idea is brought to the board. And then they are assembled throughout the life of the freestanding birth center. The next step is to gain support from the board of directors, and that could take anywhere from 6 months to a year. It's a big job, and most boards do not understand why any federally qualified health center would want to open a freestanding birth center. The next step is to secure the birth center site and then finalize the agreements with the architect and the contractors and start building that birth center. Then we're going to hire key birth center staff, and that birth center staff will then begin to implement the operational parts of the birth center. Around step 4, Medicaid becomes involved and they send an inspector down, and it takes up to a year to actually be licensed, but it happens concurrently with the building of the birth center. Again, hiring that key birth center staff, and then birth center operations being set up, licensing and accrediting coming to be finalized, and then opening the doors. So because I oversimplified that process as a part of my project, I put together a tool for FQHC CEOs that would guide them through the steps in a more detailed way of owning and operating their freestanding birth centers. And I want to just give you a little idea about how it goes. Okay, that's not going to work, so we won't do it. So my future research and next steps. My recommendations for research are, as more FQHCs open and operate freestanding birth centers, we'll be able to collect much needed research that will demonstrate the benefit of midwifery. Right now, there are 3 freestanding birth centers that are owned and operated by FQHCs throughout the country, and we really need more data. We need more birth centers to open, and that will inform further research and support for opening freestanding birth centers that are owned and operated by FQHCs. We need to include the improvement in birth outcomes for African American birthing people and the cost savings realized by taxpayers in Louisiana because of FQHC owned and operated freestanding birth centers. Other recommendations are a compilation of data from the existing 3 FQHC birth centers into a published paper to establish evidence, and drafting of legislation for federal recognition of the CPM credential. The reason why that's important is because until CPM, certified professional midwives or licensed midwives, are federally recognized, there's difficulty to having them work in freestanding birth centers that are owned and operated by FQHCs, which is a federally funded clinic or center. And so the importance of this is that CPMs are the major providers in the existing freestanding birth centers that are outside of the federal system, and they are the midwives that are bringing forth the data that is supporting the benefit of freestanding birth centers. So we need to get them licensed federally, and I hope that someone will pick up this project and move closer to the reality of federal recognition for CPMs. And then next steps, this project recommends that the state of Louisiana, via the Louisiana Secretary of Health, establish a path that allows licensed midwives and certified midwives to work at FQHCs. And so this would just be a state plan amendment. So it's in lieu of federal legislation, but supporting federal legislation. And also to work with FQHC leadership to design and implement midwifery-led freestanding birth centers, to assist out-of-hospital midwives with Medicaid enrollment and credentialing, and to assist out-of-hospital midwives to secure required and necessary insurance policies. For more information about freestanding birth centers and midwives, you can visit the American Association of Birth Centers. You can visit the American College of Nurse Midwives for more information about certified nurse midwives. And for more information about certified professional midwives or licensed midwives, you can visit the Midwives Association of North America or the National Association of Registered Midwives. And I am at the end and happy to have questions.
Just a round of applause for this, JayVon. It's incredible.
Thank you.
Thank you for sharing. I'll open it up for questions, and there's one already in the chat, JayVon, so I'm just going to read it out for you. And then if folks have questions and want to raise their hand or put it in the chat, I'm happy to direct your questions towards JayVon. So the question in the chat, JayVon, is, those are stunning stats from the Family Birth Center in DC. Thank you. Can you talk about other workarounds for CPMs to be the providers at FQHC birth centers before federal CPM recognition?
Thank you. Sure. So in California, we were able to use a loophole because of the California Comprehensive CPSP program. And so that program is recognized by the federal government, and it's also recognized by the state, and licensed midwives are approved providers. So by default, because of the recognition of the program, licensed midwives are able to work in FQHCs under a very limited capacity. But the answer to that, until we have national legislation, is state plan amendments. And like I suggested for Louisiana, there are plan amendments that will allow licensed midwives to be care providers, and they are approved through the federal government.
Thank you. Any other questions or comments? JayVon, I'll ask you a question. What do you think, because like you said, it's a genius solution. Why do you think it hasn't been widely pursued or accepted, not just in Louisiana, but throughout the US to have more, because I think you'd mentioned there are 4, right, throughout the US?
Three.
Okay. Why do you think, what are the barriers generally that folks are facing to not open more of these?
So I think there's that community fear of birthing outside of the hospital. And so just like home birth midwives get, birth center midwives, sometimes the first thing we hear is what happens in case of an emergency. And so it gives trepidation to the boards of the FQHCs and to the community. Also, people just don't know enough about out of hospital birth. And so they don't understand why it's important. Even, birth center, not birth center, even FQHC board of directors and other providers in FQHCs, they don't really understand the benefits of out of hospital birth. So they've never seen data that shows that cesarean section rates are reduced. They only hear the negative parts of birth outside of the hospital. As a culture and in society, we also are really encouraged to have pain medicine in birth. And so, many people just support going to the hospital and they wonder why anyone would ever have a baby outside the hospital. So I think there are many dynamics, but with more information, the more we talk about the benefits, the improvement in outcomes, we will get closer to the spot where we understand the importance and the value. Again, I don't think that those who really care about the money that's wasted or overspent in medicine, I don't think they understand that 5 billion potential cost savings.
Okay, there's another question in the chat, a couple of them coming in. So I'll take them one at a time here for you, JayVon. A question in the chat. I am also curious as to the geographical distribution of these 3 freestanding birth centers plus FQHCs. Can you tell us where they're located?
Sure. So one of them I spoke about, and it's in DC. There's another one in Chicago, and people rarely hear about that in my experience. And then there's another one in California in Marysville. There used to be 4. It used to be Marin City Health and Wellness Center, but that one is currently temporarily not operating. So we'll bring that back soon.
Okay, and then this is actually just a comment for you. I don't see a question in here, but I'm going to read it. JayVon, this is incredible, and I hope midwives from every state, territory, and district join with you to work on the unique issues within their own jurisdictions. All the indicators are there. The birth outcomes, the financial aspect, the customer satisfaction. Bravo on moving this idea forward in such a concrete way.
Thank you.
Few more here for you. Speaking to the 5 billion in savings, you presented another stat of 1.9 million in costs. Can you clarify?
Sure. That first one was just the cost of a Medicaid birth, just saying that Medicaid covers birth and this is a percentage of the cost. That other one was preventing interventions, preventing some of the unnecessary medical therapies that we apply during the perinatal period.
Great, thank you. Another question here, is there a pathway for existing birth centers to become an FQHC? Would we be able to have access to the toolkit you've created?
So yes to the toolkit, because I can control that, but there's a process. So yes, freestanding birth centers can become FQHCs, but that's a much greater project. It depends on the services already available in your area. It depends on how many clinics are funded. And so every now and then there are new funding opportunities, and those opportunities allow the development of new FQHCs. It's a large undertaking, and in lieu of that, if you have a freestanding birth center and not a lot of time or money to invest in the FQHC process, there's a potential to contract with FQHCs. FQHCs benefit when birth outcomes are improved because we get incentive based on good outcomes. And so If birth centers are doing the work of improving outcomes, FQHCs will get that benefit, that financial benefit, and be supportive. But it's not that easy. I mean, the work still has to be done with the board and with the leadership, because the OBGYNs really control birth in the FQHC world. I just want to point out that one of the ways that we were able to do that is to open a freestanding birth center is because I'm a midwife. And so I think there's value in midwives rising to leadership so that we can influence the development of freestanding birth centers. If I had not been the CEO and a midwife, I don't know that anyone would have found value in the idea, because their messaging would have come from the OBs who were at the time terrified. And so it really, leadership really matters.
Absolutely. Thank you for adding that component in. Any other questions? Go ahead, Wendy.
There's a comment for you, JayVon, from Dr. Nancy Anderson. And she says, my comment is congratulations, and I really appreciate your perseverance. This is essential work for all of us who want to create birth equity. Keep doing this.
Thank you. Thank you so much.
If anybody would like to ask a question directly, feel free to raise your hand by clicking on reactions in the bottom toolbar of your Zoom, and then click on raise hand, and we can unmute you to ask your question directly.
One more comment here I see come in, JayVon, that says, yes, midwifery leadership should be encouraged, with a lot of exclamation points.
It matters.
Just give it a few more minutes here for any other questions or comments that want to trickle in. As Wendy said, please feel free to raise your hand if you'd like to speak directly.
Can I make a comment that's a little bit outside of my project? I see Kiki Jordan is on watching the presentation, and Kiki is the first CPM that made history by being the CPM to lead an FQHC owned and operated birth center. So everything was experimental and she persevered. But she is the epitome of this model, because we worked through the system and found loopholes, and she became the leader.
I just want to say this is amazing, super inspiring. Thank you so much for doing this work, JayVon, and for continuing this vision, and also for the call out to continue the work to include CPMs in the Social Security Act and get federal recognition for CPMs, so that we can continue this work of making midwifery care accessible in this model. The two have to come together. So just so proud and so honored to have worked with you. Thank you.
Thank you.
There's another person in the chat, Marlenia Watkins, that is also saying thank you for all your hard work, and I'm so proud of you.
That's my mama.
Oh.
Thank you.
I know we're just giving it a moment of silence here, because I know sometimes people just need a minute to process before their question they're dying to ask pops into their head. Okay. Well, another round of applause for you, JayVon. I am so proud of you. As your timeline showed, you had a lot this year, and you handled it with so much grace, and it was truly an honor to be a part of this process with you. Much love to you so much. And I'm very excited to watch you walk across the stage tomorrow.
Thank you. I'm excited to walk across the stage, so thank you.
Okay. Okay, well, I think the plan now is to take a little break for about 9 minutes. Our goal, again, like Dr. Gordon had said earlier, is to start at the top of the hour with our next presentation. So if folks want to go refill tea or coffee or water or a bio break, we'll see you back here in about 9 minutes.